Welcome. If you're getting ready for the AFK exam, you know radiographic recall is pretty much a guaranteed topic. So today, we're going to break down the official guidelines, really master those key intervals and principles so you're totally ready for exam day. Okay, let's just dive right in with the single most important principle from the ADA and FDA guidelines. Seriously, this one sentence is the foundation for everything else we're going to cover. It basically says radiographs are a diagnostic tool you use after a clinical exam, never as some kind of routine screening tool before you've even looked on the patient's mouth. So, here's the bottom line. Every single decision to take an X-ray has to be based on an individualized assessment. We're talking about a proper clinical exam and a detailed patient history. This is a huge shift away from the old school idea of just, having a routine, one-size-fits-all schedule for everybody. So how does this big principle actually play out when a new patient walks into your clinic? Let's break down what to do for that first encounter. What's really key here is how this tailored approach works in practice. So for a little kid with primary teeth, if you can see and probe between their teeth because the contacts are open, you might not even need to take any X-rays. But for a child in that transitional phase, you're looking for more than just caries, right? You're also monitoring development, which is why a panoramic exam can be such a great tool. Now contrast that with an adult who comes in with clear signs of generalized disease. In that situation, a full-mouth series is really what you need to get the complete picture. It's all about tailoring the exam to the evidence you see right there in the chair. Okay, so that covers the first visit. Now let's switch gears and talk about recall patients. For these patients, the number one concept, and honestly the one that gets tested the most on the AFK, is figuring out the right time-based interval for their posterior bite wings. And that interval, it all comes down to one critical factor: the patient's current caries risk. So you can just forget about those old fixed schedules, every 6 months or every year. It's your professional judgment in assessing their risk that dictates how often you take films. This is the core skill the exam is looking to test. So, let's get into the specifics, the high-yield numbers you need to know. If you have a recall patient, and you've assessed them as having an increased risk for caries, what are the recommended bite wing intervals? Here are the numbers you absolutely have to memorize. For a high-risk child, doesn't matter if it's primary or transitional dentition, it's a very tight interval of 6 to 12 months. For high-risk adolescents and adults, that window opens up just a little bit, to 6 to 18 months. These shorter intervals make perfect sense. They're a direct response to a higher chance of disease progression. Okay, let's flip the script. What about a recall patient who comes in with no clinical caries and you've determined they're at low risk? How much do those intervals change? You'll see it's pretty dramatic. And here is where you really see that risk-based model in action. The intervals stretch way out. For a low-risk child, it's 12 to 24 months. For a low-risk adolescent, it goes all the way up to 18 to 36 months. And for a low-risk adult, we're talking a full 24 to 36 months. That could be up to 3 years between bite wing radiographs. So you might be wondering, why are the intervals for kids shorter even when they're in the same low-risk category as an adult? Well, it's all based on the science of how fast caries moves. The evidence shows that, on average, a cavity can get through primary tooth enamel in about 1 to 2 years. But in permanent tooth enamel, that same process takes over 3 years. The guidelines are a direct reflection of that biological reality. And of course, the principle that underlies all of this is ALARA, as low as reasonably achievable. Stretching that recall for a low-risk adult to 36 months, that is a perfect, real-world example of ALARA in practice. We're minimizing exposure because the chance of finding something new is really low. Okay, so this entire system really depends on our ability to accurately figure out a patient's risk level. So, how do we actually do that? How do we objectively decide if someone is high risk or low risk? We do it by conducting a caries risk assessment. And as you can see here, it's really a balancing act. On one side of the scale, you've got the risk factors, things like a mother with active cavities or frequent sugary snacks. On the other side, you weigh the protective factors, like living in an area with fluoridated water or having a regular dental home. The final balance is what tells you their risk category. Now, for the AFK exam, you've got to be on the lookout for these key disease indicators. In a test scenario, the presence of any one of these, like new white spot lesions or even just visible heavy plaque, is often enough to immediately push that patient into the high-risk category, which of course triggers those shorter recall intervals. All right, let's put it all together in a quick recap. These are the 5 critical recall intervals that you absolutely must have memorized for your exam. Let's run through them. First up, 6 to 12 months. This is your high-risk child. Next, 6 to 18 months. That's for your high-risk adolescent and adult.
Okay, now for low risk, 12 to 24 months. This is your low-risk child.
18 to 36 months. That's for the low-risk adolescent. And finally, the longest interval, 24 to 36 months. That is your low-risk adult. Got 'em. So there you have it, the complete framework. It all starts with that core principle of individualization, then relies on a solid carries risk assessment, and that leads you to a specific evidence-based interval. Now you have the knowledge. The only question left is, can you apply it under pressure when you see it in a complex clinical vignette on exam day?